Very much. So good evening, everyone. Thanks so much for joining. It's terrific to see so many students, faculty, and staff alike. I have the pleasure of being the moderator for this evening's conversation with Rafael. And I thought I would begin by asking a few questions. I'm sure others will have comments, questions, of their own. So please feel free to use the chat. I know often in these kinds of sessions, the chat can often take on a life of its own, where people are asking and responding. And so please do that. If there are any questions specifically for Rafael, we'll have time for that at the end for sure. I will try to keep on top of the chat. Anjali will as well. But we want to make sure we get to as many questions as we can. And if for some reason we miss a question, you can, of course, feel free to unmute yourself and just pop right in. So, but with that, why don't we go ahead and get started? I want to make sure we get going here, and we might have some others joining along the way. But let me begin by thanking Rafael for doing this, this conversation around neocolonialism and global health. And really, three questions that I wanted to start off with is, one, why did you decide to do this, host this conversation? And then thinking about the title and breaking that down in terms of what is it that you mean by global health and neocolonialism and why it's important. But let's start just to kick it off by, what is it that prompted you to host this conversation, Rafael?
Yes, thank you very much, Mayur, for being our wonderful host tonight, first of all. So at my last town hall meeting with the Global Health Concentration students, they really expressed a lot of concerns about what they are seeing globally with regards to major global health inequities and what they perceive to be a very flawed global health system. So based on that conversation, I really got inspired to try to share some reflections and have a conversation as to why not only I, but why do we all think that the poor health outcomes are so inequitably distributed within and across countries all over the globe. And secondly, that we want to understand better collectively, why do we have the global health governance architecture that we have? And is there anything that we can all try to do, especially being an academic institution, to try to change the status quo? Secondly, my personal experience growing up in Mexico, which is one of the most inequitable and unjust countries in the world, it really opened my eyes since I was a very young child about really the major legacy that colonialism left in our country, and how those very, very unfair structures that were set up by the Spaniards that conquered Mexico had really remained for us for centuries. And then subsequently, who would know that I would become a global health scholar? And now I have worked in over 20 countries in all world regions. And it's a very consistent pattern that I have seen, the one I have seen in my own Mexico. So that's a second motivation that has led me to have this conversation, because being the son of a Mexican art historian, I understand the importance of understanding history to actually change inequitable conditions or systems. And last but not least, because of COVID-19, I predict that global health is going to now become even a more popular choice among many of our future students. So in a very selfish way, I also want to have this conversation to see how we can always improve our own global health concentration to prepare better our students to help shape a more equitable global health system. So those are the three main motivations that drew me to have this conversation today, Mayur.
Great. No, I think that really tees us up nicely and sets up this conversation, because I think there are, looking at a number of our students and knowing many of them myself, and others on the call, I think your experience of growing up in Mexico and then having that influence the kind of work that you ultimately have gotten into, I think will resonate with a lot of our students and a lot of those on the call. And so it'll be really interesting to hear people's own experiences of how that has helped to shape the kinds of work that they want to do. And also, I suspect that many of our students want to go into positions at agencies like the WHO or the World Bank or a variety of types of places, and yet thinking about how they operate and how they want to operate within those kinds of systems. So I think this is so important and timely. But getting to the title, so you titled this conversation Neocolonialism and Global Health. So let's break that down. When you think of global health, what is it that you have in mind when you use that term?
Yes, so global health is the area of public health that is concerned with the spread of disease across countries and world regions. Global health problems, we know, can concentrate in just a few countries, as it happened with Ebola, that it concentrated very, very heavily in 3 West African countries, or pretty much globally, as is the case with the current COVID-19 pandemic, or the HIV pandemic, or the obesity and NCDs, such as heart disease and diabetes pandemic, or the mental health problems pandemic. So I think that we are seeing more and more and more and more the very profound links between social inequalities and health problems and climate change as becoming truly, truly global in nature. You know, as some of the astronauts can say, from space you cannot see the artificial borders that humankind has established. In global health, it doesn't see those either, or the agents that cause these problems, they don't see at all those borders. So getting more into the issue of neocolonialism, it is very interesting that the term global health has just begun to be used relatively recently. Before then, for decades, the term that was used was international health. And that term reflected a very highly patronizing concept, focusing on the lens that high-income, powerful nations needed to help low-income countries to solve their public health and other problems that they had. This definition was a direct result of colonialism, which saw the world through the lens of superiority of one race over another. For example, it is undeniable that racism was behind the justification for the extraordinarily painful cultural genocides that colonizers inflicted in local populations to take over their lands and resources. And the major enduring public health problems that still persist today, centuries after many of these initial traumatic events started to happen as a result of colonialism. So after the end of colonialism in most parts of the world, we can actually see what the consequences of that thinking has been. And you don't need to take my word for it. Just look at the current health statistics for Native Americans in the US, or indigenous communities in Mexico, or the Aboriginal people in Australia and New Zealand, or the people from the Marshall Islands where the US decided to test nuclear weapons, or the people from Vieques in Puerto Rico where the US decided to use it as a bombing range for 6 decades against the will of the local population, and having very strong evidence that this was harming their health and natural environments. So the issues with neocolonialism have been extremely consequential for the architecture of global health governance and the way we see the health problems very inequitably distributed across countries and world regions. So this is because the neocolonialist approach in public health is rooted in an unjust social, political, and economic system that essentially was established since the colonial times, where the less powerful countries were forced to depend very strongly economically on a very few powerful nations that started control the wealth of the world through a very inequitable distribution of power. The neo-colonial approach is extremely detrimental to public health because it assumes that local communities have only problems. They don't have assets. They don't have anything to contribute. All they have are problems, and only whites or foreigners know how to solve them. In other words, it totally ignores the fact that all communities, all cultures, all countries have very strong cultural and social assets. It assumes that people who don't belong to the race or social status are essentially ignorant. So in other words, it is based on what we call the white saviorism approach, and hence it is intrinsically racist in nature. There is no other way that I can understand what is at the essence of neocolonialism. When we try to operationalize neocolonialism in the context of public health, there are 4 very key aspects that I wanted to talk about today. First, the first aspect is that it really is based on very powerful nations imposing top-down solutions without consultation with local communities. Second, the intention of, or the goal of improving health is not based really on advancing the human rights of the health of local populations. In many instances, many of these global health efforts were designed by former colonial powers so that investors and citizens from their countries could be safe and can profit from the exploitation of natural and other resources in the lower income settings where they started operating. So it is driven by hugely inequitable economic growth, which is nothing but greed at the end of the day. The third aspect is its very strong emphasis on biomedical solutions, on really trying to find silver bullets for correcting malnutrition, trying to find silver bullets for correcting every single global health problem that we can imagine, without paying much attention to the social determinants of health, which essentially are also part of the UN Human Rights Charter. That is, that at the root of almost all these problems, it's a combination of lack of access to healthcare, to food security, to quality education, to decent household and living conditions, including sanitation and so on. And fourth, a lot of these efforts have focused really on extending life expectancy without paying any attention whatsoever to quality of life. So the counter argument that we oftentimes hear is that why do we criticize so much neocolonialism if at the end of the day, life expectancy has improved globally? So my response always is most of those improvements in life expectancy have been driven by addressing sanitation and food security, mm-hmm. and preventing communicable diseases by addressing in many ways social determinants of health. So it is not because of the neo-colonial approach that has happened. And at the end of the day, what is the purpose of people living for longer if the quality of life for a very, very large proportion of people in the world is really living under inhumane conditions. So I'm going to stop at this point with that long answer, but I really tried to tie in as best as I could how neocolonialism fits in the context of global health.
Yeah, no, thank you so much for that, Rafael. You know, I definitely want to then get to being able to open it up to more conversation. But, you know, a couple of things that struck me is that, you know, even thinking about the language that we use, global health, and the old term that we used to use, international health, you know, I think even as we think about the colloquial use of the word international, that sets up a contrast between what we might think of as domestic. And so when we think in those kinds of terms, it makes me think about, well, if we contrast domestic issues from international, it's putting the focus on us here in the United States and those problems and those issues that exist outside, and leads us to thinking about what is it that we can do about that, and not necessarily recognizing that we have a role to play in those issues that exist outside of the US. And in contrast, using a term like global health puts us squarely within the global health community, and sort of decenters the United States from our thinking of these global health issues. So I think, you know, you're illustrating that language matters and how we think about that. And then, you know, the ideas of neocolonialism, as you were talking about that, it makes me think about, you know, the kinds of research and training programs that many of us are involved in, and to what extent we're having genuine, authentic collaborations and co-creating our programs with our partners, or are there ways in which we are operating that have the legacy of neocolonialism, and so, you know, really has made me think about, you know, how, and perhaps others will be able to chime in about how they think about the work that they do in different settings. So I think there's a lot there for us to think about. Zooming out a little bit, little bigger picture, how do global health governance systems work, and who runs them?
So at the end of the day, you know, the global health system has been governed by over a century through a very powerful alliance. Some people say, oh, things are not working because there isn't a well-organized global health governance system. And I would argue that is not the case. It is very intentional the way it works, and it is very well organized. And this very powerful alliance has been formed by financing so-called developmental assistance, international health organizations, private foundations. I know that we all admire a lot of the work that now the Rockefeller Foundation is doing. But when the Rockefeller Foundation started investing heavily in international health at the beginning of the 20th century, they were totally pushing through their way based on a very neo-colonial approach. The Bill and Melinda Gates Foundation, for example, is now the third biggest funder at the World Health Organization. We also have the government foreign aid agencies like USAID, like the Canadian International Development Agency, the agencies from Japan, from Sweden, even, you know, from China, that they're very much immersed in many parts of sub-Saharan Africa, and of course, the private sector. So the pharma industry is very deeply involved in the architecture and really the intentionality of the current global health systems. I want to mention that when it comes to foreign aid agencies, for example, I worked in Ecuador in the 2000s at a time when there was an enormous social, political, and economic crisis in the country. The government essentially became defunded. They had only money to pay salaries, but no money for operations. So essentially what happened was that the country was divided into sectors. You can think almost of Berlin, like the Spanish Developmental Aid Agency would take care of one sector, the Japanese of another sector, the Norwegian of another sector. And there was so very poor coordination among them. And it was extremely difficult actually coordinating the national breastfeeding program that I was tasked to help advise USAID on how to go about it. So I saw firsthand, how in the middle of enormous crises that in many ways are also the legacy of neocolonialism and that pushed the indigenous populations in Ecuador to the brink because of these enormous injustices. And then the same governments that in many ways were responsible for creating those situations send their developmental agencies to then solve those situations with their own agendas, their own approaches, and so on. So this alliance is very, very powerful. Having said that, some of the good news is that in some ways, I think change has begun. We all know that the World Bank, the World Health Organization, do take now into consideration the social determinants of health, even though there isn't a lot of funding still to design and develop sound, sustainable interventions through that approach. We're still very biomedical, but we know that the World Health Organization established a very influential commission on the social determinants of health led by Michael Marmot, who actually came to speak to the Yale School of Public Health a few years ago. So the realization is that UNICEF, for example, since the 80s, they were talking about economic adjustment with a human face. They were questioning the IMF and the World Bank and the chaos they were creating in the countries, were forcing them to make enormous sacrifices that would affect the poor the most by reducing government expenditures in social programs and so on. So the good news is that several of these key partners of these alliances realize that there is no way out of this crisis unless we really fully address the social determinants of health and we really look at it from an equity lens. They are still trapped in the neo-colonial global health governance system with which they were born, but hopefully, there will be more substantive change on this in the year to come now that we have a better understanding and better blueprints to follow based on social determinants of health. A second piece of good news is that we do now have very powerful examples of South-to-South cooperation. That is cooperation among lower income countries that has not gone through higher income countries or is not being driven by top-down neo-colonial approaches. So one example is the production of generic drugs that started with the HIV pandemic and the need for countries like Brazil to offer universal antiretrovirals coverage, no questions asked, and they just couldn't afford to pay the outrageous prices that the drug companies had placed on those drugs that were essential. So what happened in Brazil was that the Constitution guaranteed the right to health of its citizens. So a very poor woman in Rio de Janeiro who was infected with HIV could not afford to buy the antiretrovirals, even though they were becoming more and more effective. So a human rights lawyer represented her and sued the state and said, you're violating her human right guaranteed in the Constitution. So the government used that excuse to confront the pharmaceutical industry and gave them an ultimatum: you either reduce your prices or we start producing generic the drugs. And to make a long story short, the pharma ended up reducing the prices. And as time went by, Brazil learned how to produce that and other drugs generic, and they started forming alliances with India, with China, and other countries. And they developed a massive program of generic drug production, pretty much having public health and reducing inequities in mind. We're also seeing, for example, in the area of human milk banks, how Brazil developed the most extensive and sophisticated network of human milk banks, a lot of which is crucial for the survival and thriving of premature babies. A lot of this milk is used with premature babies. And then Brazil became the technical advisor for the rest of the world on the establishment of milk banks, following a not-for-profit approach. Also, for example, the anti-obesity policies that have been established in Latin America have now placed Latin America light years ahead of the US when it comes to policy-level solutions to the problem of childhood obesity. So the most influential and substantive set of taxes imposed on sugar-sweetened beverages happened in Mexico. And then it started spreading to other countries in Latin America. And then it reached the shores of the US, where Berkeley and Philadelphia and other cities started implementing those sugar tax policies, and they're now all over the place. So now it's the South in many ways teaching the North how to go about implementing those policies. Front of package warning legislation combined with protection against marketing of junk food for kids. Chile is the leader in the world, and we're all seeing how those black octagons with those warning signs are making their way all over the world. So those are encouraging signs. It tells us that if we continue following an approach of reflecting on neocolonialism and understanding what led to it and why we have the global health governance structures that we have and systems that we have, then we can start unraveling it. And it's happening a country at a time, a topic at a time, but the question is then how can we do it in a systematic way to turn the tables around and really start a new day with a much more humane and equitable global health governance structure in the near future.
Yeah, I mean, I think you know, emphasizing the successes that individual countries have had, as well as these really crucial South-South cooperative successes is so important. I just think about, you know, we have students who want to go to work for these large agencies that drive global health governance, the WHO, UNICEF, the World Bank, all of the Bill and Melinda Gates Foundation, pharma. And, you know, it's going to be really important to think about, while change is being made, how we continue that, because there are such entrenched interests, and, you know, each one of these actors competing against one another for influence in different areas, and really thinking about how the priorities are set and who's setting them. And so there's just so much there, I think, for us to think about. And that, I guess, leads me into the next question, which is that as an academic institution, as the Yale School of Public Health, one of the premier institutions around the world, how can we as an academic institution help change the status quo? What is it that we can be doing in terms of our teaching and training and preparing our students and ourselves to be able to go out and do better work?
Yeah, so first I want to say that there is a ton of evidence that actually this very powerful alliance that led to the global health governance that we have really as a legacy of neocolonialism, actually the way they perpetuated their system was by influencing a lot how public health students were trained. So a lot of these agencies and foundations actually funded heavily universities like Johns Hopkins University, like the London School of Hygiene and tropical medicine, and so on. So I would say that here we have to deal with a counterfactual. You know, if they were very successful through academic institutions to train students following the neo-colonial lens of white saviorism, and we know better, us versus them, and essentially top-down is the only way that these people will ever improve their lives, because they are ignorant and they really don't have any assets. They have nothing to contribute to the building of equity in their countries. Then why can't we think in reverse and say, shouldn't we start a very, or continue, because the Yale School of Public Health has started this many years ago, but should we continue really looking ourselves in the mirror and saying, what is our curriculum doing? How are our courses preparing in a consistent way our students for a world that is really free of neo-colonial thinking when it comes to global health? So I would say that in many ways, our great intentions to do that are not moving fast enough. And it is because I think this has also to be a whole systems movement, not only one course, not only two courses, not only one school, but we really have to talk about, you know, really all the schools partnering together to make this major shift in the way we train our students. So I would argue that profound curricular reform is needed to really emphasize through practice learning approaches. There are very nice case studies from different countries that really have been able, for one reason or another, to take their destinies in their own hands, and not very wealthy countries, but that they actually followed a social determinants of health approach based on human rights, equity principles, and so on, and where they have been much more successful than even the most advanced or the richest country in the world, which is the US, on improving health outcomes at the same time that they are reducing inequities. So I would say that there are 5 elements in this training that we need to dwell much more into them. Social determinants of health and equity is not just a nice, beautiful concept. There is a lot of empirical evidence on why they matter so much, but we don't have very good indicators. We don't have very good implementation tools to design programs that are capable of achieving positive results using this framework. So we can do a much better job with social determinants of health and equity through practice learning approaches. Bioethics, I just think, like, you know, I work a lot in the area of infant feeding. I've been a breastfeeding researcher for over 30 years. I totally respect any choice that any woman makes about how she wants to feed her baby. If it's breastfeeding, she should be supported. If it's infant formula, she should be supported. But what is very troubling is when you have the infant formula industry pushing misleading advertising and marketing, and promoting benefits of products that they just don't have. The same happens with the marketing of junk food and sugar-sweetened beverages to very young children, and so on. So I think the bioethics of going into another country and doing research, there are ethical ways of doing that. There are collaborative ways in doing that, and there are very unethical ways in doing that only perpetuate the neo-colonial thinking. So the third element goes to the heart of this, which is community-based participatory research. That at the end of the day, in almost, I would say in all the mixed methods research that I have done, and it has been a lot, the best ideas, the best solutions have come from the community. I really cannot claim any credit for any of the good ideas that I've had, because they have come from people in the communities. Very, very wise people that have been there. They know how it feels. They know what led to it. And they just, no one has ever bothered to ask them, or no one has ever wanted to work with them on designing solutions to problems related to lack of healthcare access or food insecurity and so on. And in fact, the reason I was one of the pioneers bringing community health workers into US interventions with minority groups was because of what the communities taught me in Latin America and other parts of the world about how powerful it was to work with very well-trained community health workers. It really taught me the concept of intersectionality. I think community health workers are fabulous because they can put themselves in the shoes of the people they are working with, and they truly understand that it's not just a one barrier, it's one after another, after another, after another, but they also understand the social networks, they understand the strong resiliency that people can have when everybody starts working together, either designing projects or implementing programs. And oftentimes now we also work together on evaluating those same programs. So in addition to CVPR, based on what I said, we need to improve the training on implementation science, which is really the heart, I would say, of public health practice, embedded in systems thinking. So we're talking about global health systems. I could have spoken about the food systems. I could have spoken about the water systems, neocolonialism after neocolonialism after neocolonialism. And as time has gone by, the same corporations and the same groups are controlling all the systems. So now the soda companies are accessing and selling enormously large volumes of fresh water. Now they are in the water business, producing 1 kilogram of dry milk for infant formulas uses 4,000 liters of water. So there is a very profound connection among all these systems. And if people are undernourished, if there is food insecurity, their health status is going to also be extremely, extremely affected. And if it's also a very neocolonial healthcare system, the one that is in place, people are not going to have access to quality healthcare. So it's also important to instill much more the systems thinking approach and the need to work efficiently as part of interdisciplinary teams, because these are complex problems that require systems thinking and team science and citizen science to be addressed. So that's the fourth element. And the fifth element I want to argue very strongly is about the science of evidence-based advocacy. I have seen it in the areas where I work, that it is the way that everything starts. Like Margaret Mead, a famous medical anthropologist, would say every single important change has been the result of the effort from a small group of concerned citizens. And that's how everything starts. But there is an art and there is a science in terms of also understanding who are the key stakeholders, where the levers are, and what is the influence that different stakeholders have on the systems. And now, because of the work of professors like Nicholas Christakis, we are really unraveling the power of social network analysis and really understanding, how to influence decision making and the way systems run. At the end of the day, we cannot advocate for just changing the global health system without changing the extremely unfair political and economic systems that are behind them. So neocolonialism and neoliberal economics thinking go hand in hand. They are cut from the same cloth, and clearly they have been a catastrophe for public health globally, if we use inequities as an indicator. So those are the five elements that I would love to see strengthened across the curriculum in all schools of public health, including ours, to help the future leaders of the global health agencies and really the future secretaries of health and very, very influential personalities to really be trained in a way that we can break the very vicious and long history of colonialism following by neocolonialism, and we come up with a much public health, human rights oriented global health system.
Yeah, I know there has been a tremendous effort, certainly at YSPH, in trying to think through our curriculum in global health. Certainly from the time when I was a student here over 25 years ago, the way in which we think about global health has really evolved and reflected in the coursework, but I'm sure our students, our current students, are going to continue to hold us accountable to continually improve and advance the kinds of course offerings that we have and the approach that faculty take in the classes. And so I think that's going to be really important as we continue. I really want to, in the last few minutes that we have together, I want to open it up to students and others on the call to invite their questions. But just any last thoughts, Rafael, before we turn it over?
No, just that the good news is that it works. So the last thought I wanted to share is that I was actually worked with President Lula's administration in Brazil when he first came into power in 2003. And so with my own eyes, and I helped develop the metrics to demonstrate it, that the country was able to reduce by 30% the level of severe food insecurity, and even by a greater percent in the poorest areas in the country by massively redistributing the wealth that was coming from their spectacular economic growth through much more equitable social policies. And that led actually to a tripling of the minimum wage, very, very low levels of unemployment. So I saw it that in less than 5 years, there can be spectacular results when we change the paradigm from neocolonialism to equity and social determinants of health. And at the same time, Brazil brought the percentage of stunted children to less than 10%. Guatemala has about 70% of stunted children. Brazil brought it below 10% and eliminated completely the difference between the stunting levels in the wealthiest kids compared to the poorest kids. Whereas in Guatemala, the wealthiest kids had less than 10%, the poorest kids had more than 80% of stunting. So it can be done if we turn the tables around and do this type of governance globally.